Good evening and welcome. I'm Vanessa Hoffman, Program Coordinator for Research and Education at the Bladder Cancer Advocacy Network, Beacon. Tonight we present Personalized Medicine in Bladder Cancer, a summary of the Cancer Genome Atlas findings, part of our winter webinar series on research. Before we start, I'd like to do some quick housekeeping. We've switched to a new webinar service, Citrix GoToWebinar. You have the option of listening using either telephone or microphone and speakers. Click the circle next to the one you want. If you have any technical support issues, call the number on your screen. You should see a questions box in the GoToWebinar dialog box on the right side of your screen. Please type your questions into the box as you think of them. Try to keep them related to this webinar presentation specifically, and we'll try to answer as many as possible at the end of the webinar. We would also very much like to thank Abbott for providing a grant to support this webinar. I would like to introduce our distinguished speakers now. We are lucky tonight to hear from two speakers who directly participated in the Cancer Genome Atlas Bladder Cancer Working Group. First is Dr. Seth Lerner, who is Professor of Urology and holds the Beth and Dave Swam Chair in Urologic Oncology in the Scott Department of Urology at Baylor College of Medicine. He earned his medical degree also from Baylor College of Medicine. His clinical practice, education, and research activities are devoted to urologic oncology, particularly lower and upper tract urothelial cancer. He's authored a number of articles, co-authored a comprehensive textbook on bladder cancer, and also established and directs the multidisciplinary bladder cancer research program at Baylor. He's very active with Beacon as a member of the board of directors, past chair of the Bladder Cancer Think Tank, and also part of the Bladder Cancer Research Network. Our other speaker is Dr. Jonathan Rosenberg, who is with the Memorial Sloan-Kettering Cancer Institute as section head for non-prostate genitourinary malignancies and associate attending physician in the Genitourinary Oncology Service. He focuses on correlating novel genomic findings with clinical outcomes in bladder cancer, as well as developing and testing new treatment strategies in bladder cancer. He received his undergraduate degree from Duke and his medical degree from Harvard Medical School. He's led many multi-institutional trials in bladder and prostate cancer, and has also been very involved in Beacon. The speakers will present for approximately 20 minutes, and then we'll answer questions for about 15 to 20 minutes, which I will read out. You're welcome again to type in your questions as you think of them, and please keep them relevant to this presentation and topic. So let's get started.
Hello?
Hey, Seth. I just transferred over.
Got disconnected. Apologize. Okay, we're ready to go. So, Jonathan?
Are you not seeing the screen?
Did you pass it off to me, Vanessa?
I believe so.
Let's see.
Vanessa, are you seeing?
Not yet. Do you see a pop-up window, Seth? Okay, great.
No. Terrific.
All right, you're good to go.
So this is Jonathan Rosenberg. Thank you very much, Vanessa. I'm very happy to be here to be discussing these very exciting findings with my friend and colleague, Dr. Lerner. We're going to have what I would say is a dialogue about this, presenting a summary of the data for the listeners on the call, and really think about how this can be used to help patients. So unfortunately, as many of you know, bladder cancer that has spread does not necessarily have durable responses to chemotherapy treatment. In almost all patients, unfortunately, with metastases, cancer becomes resistant to chemotherapy, and other drugs, other chemotherapy agents are not very active. Many agents have been tested, but new chemotherapy drugs have not really proven to be the breakthroughs that we had hoped for beyond platinum-based types of chemotherapy. In addition, chemotherapy can be associated with significant side effects, and occasionally these could be very serious and even life-threatening. Next slide. So most cancer treatment for bladder cancer is a one-size-fits-all type treatment. While we try to select our patients for different types of therapies, we really do not have a molecular way to assign a patient a particular therapy. We assign treatments to patients based on their general health, the function of their organs, but in large part it's a one-size-fits-all type treatment, and chemotherapy is the best example of this approach. One major goal of cancer research is to personalize the treatment for cancer, to match the treatment to the individual patient's cancer, so that you are giving a treatment that you would predict that patient might be more likely to respond to compared to a treatment that you pick out of your toolbox without any prior reason to think it's going to work very well. Sequencing the DNA of tumors can identify genetic changes, alterations, or mutations that exist only in the tumor and might be driving the cancer to grow and spread throughout the body. Next slide. There are many, many new cancer drugs being tested in cancer throughout different types of malignancies. And there are many drugs that are approved for use in other cancers that are targeted agents that target some of these genetic changes that we are identifying in bladder cancer. Unfortunately, none of these drugs are approved for bladder cancer, and most patients cannot access them because of the lack of FDA approval for these drugs, and because often the cost is very high. And so we're struggling with the ability to test these drugs in the right patients in bladder cancer to identify patients who might be likely to respond. A particular drug might be expected to work in a patient with a particular genetic change within their tumor, but not in someone without that genetic change. And this is the theory behind personalized medicine in bladder cancer. This has worked in lung cancer and melanoma and other cancers, but to date remains relatively untested in bladder cancer. And the TCGA is one way that we're getting more information. The Cancer Genome Atlas is one way we're getting more information about the genetic content of bladder cancers on a population basis to allow us to understand this better. Next slide. So since the introduction of cisplatin-based chemotherapy approximately 30 years ago, there really has not been any major advance in the treatment for urothelial cancers. We've made progress in reducing side effects, but we really haven't come up with a new, highly effective treatment for bladder cancer. Over the last few years, there have been reports describing common genetic alterations in bladder cancer, and many of these have started to shed some light on the biology and the potential therapeutic targets for drug development. Seth, do you want to take over for a few minutes?
Yeah, I was offline there. Now I'm back online. Okay. So the Cancer Genome Atlas project is funded by the National Cancer Institute, and this was started several years ago. And it is a collaboration of scientists and clinical centers that all over North America. And so patients who have a biopsy, a sample of their tumor is sent to a central repository where quality control is done on the pathology specimen. DNA and RNA and protein are isolated and then sent out to various sequencing centers that look at the DNA mutations, the expression profiling with RNA and protein, look at epigenetic changes in the DNA, and then all of that sequencing data gets stored in a central repository, and then it goes into a very comprehensive characterization of the genome, and a term that we use called integrative analysis, where you can combine multiple data types to get a more sophisticated understanding of the biology of the tumor. A project takes typically about 3 to 4 years start to finish. In the first phase of the project, a disease working group and the bladder disease working group got constituted now nearly 4 years ago, essentially designs the study, puts all the parameters together, and then as tumors start going into the biospecimen processing, all of these different platforms that look at DNA and RNA in different ways are done by some of the world's leading experts in different centers, and then an analysis working group, or AWG, is constituted to essentially take all of that data, analyze it, determine what it means, and then the end result of that is a paper that's typically called a marker paper, and it essentially is the comprehensive characterization of the genome of the particular cancer. So think of this like a human genome project for, in our case, bladder cancer. To just give you, in the next slide, an idea of the scope of this amazing project funded by the National Cancer Institute, what this graph shows is the progress of 25 different tumor types, solid malignancies, and the red bar indicates that the first paper has already been published, and on across on the left side is the number of tumors that went into that data set. Green bars are analyses that are underway, and then on the right-hand side are rare tumor projects which are in various stages of development. The great thing for urologists and medical oncologists who are interested in genitourinary cancers is that this project is now encompassing all of the 4 major tumor types that we take care of, and we're very happy that the paper that we're talking about today was published just last month and is available online to researchers all over the world. So the goal of the project is to really gain a better understanding of the spectrum of genetic alterations and non-genetic alterations in bladder cancer, with the hope, as Jonathan outlined, to identify new targets and new treatments instead of a one-size-fits-all. This particular project focused on the most serious form of the disease, and that is when urothelial cancer has invaded into the muscle, or deeper, when patients will typically require some combination of chemotherapy, surgery, and radiation, in order to be cured. So the specifics of this study required no prior chemotherapy. Patients could have had intravesical or therapy with BCG, which is a very common treatment for non-muscle invasive bladder cancer. And then the marker paper was based upon 131 tumors that were the first set of tumors that went through this very sophisticated type of analysis. And DNA alterations were identified by sequencing, where to look at all of the potential mutations or alterations in the DNA, and also to look at DNA that was amplified or lost, and integrating that into the mutation analysis. And then I think in the next slide, I'll just show you some of the descriptive data. So in this top left-hand corner, this defines the muscle-invasive group of patients. About a third of the patients already had spread to the lymph nodes. That's N+. And as is fairly typical, what N1 means a single node, N2 is multiple nodes, and N3 is lymph nodes higher up in the pelvis, and is very common. The majority of patients with positive nodes have multiple positive nodes. As you may be aware, about half of this type of bladder cancer is typically associated with cigarette smoking. For some reason or other, in this data set, there was a higher percentage of this. About 3/4 of the patients had a positive smoking history. And this will theoretically give us an opportunity to look to see if there are any associations with any of the genomic alterations identified with a positive smoking history. So far, we have not found any associations. So there were a number of really very interesting findings, and Jonathan and I will run through these in the next several slides. One of the really interesting things is that bladder cancer has one of the highest mutation rates among any of the 25 tumor types that were analyzed in the TCGA data set. And similar to other carcinogen-induced malignancies, lung cancer, which you're most likely aware is associated with cigarette smoking, and melanoma, which is associated with ultraviolet light from the sun. And so these three, lung, melanoma, and bladder, have the highest mutation rates of any of the tumor types studied. This is compared to other urinary tract cancers, which have been found to have very low mutation rates. Renal cell, which is the most common form of kidney cancer, and prostate cancer. And as I mentioned, so far we don't see any association of cigarette smoking, but as we get more tumors in the pipeline, so to speak, for analysis, we'll be taking another look at that. In the next slide, this is just a big picture of the mutation findings. There were 32 genes that showed significant levels of mutations, and there's a statistical analysis that determines what we refer to as a significantly mutated gene. And these genes, not surprisingly, affect multiple different cell signaling networks, and these include genes that control cell growth and division, how cells communicate between one another, how cells respond to DNA damage, for instance, by carcinogens, how they control gene expression and detoxification. And this is only a partial list of some of the networks and pathways that are involved in bladder cancer. In the next slide, signaling pathways are essentially how cells communicate with one another and function normally, and in this case in cancer, abnormally. And these send signals for cells to divide and grow, and it's sort of like a light switch being turned on and off. So if you think about malignancy, the cells have really lost the normal controls that allow a cell to divide and replicate in an orderly fashion, and cancer is just simply the loss of those controls. And so in many cases, the light switch is sort of turned permanently on, telling the cells to continue to divide and grow, and that's essentially the underpinnings of cancer. And so bladder cancer has many of these pathways that are altered and in the permanent on position. And so this project, looking at multiple pathways, multiple genes, looking at mutations and expression, allow us to pull all these data together to understand some of the complexities of how these pathways relate to one another. So I'm going to turn it back over to Jonathan in the next slide.
So as Seth mentioned, these bladder cancer cells and cancer cells in general don't obey the usual stop signs, the signals to say stop growing and stop dividing. And then many of these stop signs are broken. So these are the things that tell cells not to grow and not to divide. And often at the same time, they have the accelerator in the on position, essentially. And so you remove the brakes and you put on the gas, and bad things happen with cancer cells. And in general, these mutations lead to increased cell division and unchecked growth. Seth, next slide. So one pathway that's activated in bladder cancer, and I'm going to go through a series of pathways for which we think there will be clinical promise in investigating over the next several years. And these are findings that are coming out of the TCGA as well as other scientific research. So the CDK4 pathway is a pathway that is flipped on in probably the majority of bladder cancers. It's a cell cycle, what we call a cell cycle regulatory pathway. It regulates when cells enter cell division and divide into two cancer cells. Overall, most bladder cancers have some part of this pathway turned on. There's a whole class of inhibitors called CDK4 inhibitors. CDK4 is a protein that signals along this cascade of events that leads to cell division. In breast cancer, there's been a lot of buzz and promise about a particular CDK4 inhibitor called palbociclib, which is a mouthful, where it's shown fairly significant promise in treating breast cancer. And testing of this drug in bladder cancer and testing of other drugs in this class in bladder cancer are planned over the next several years. And so there are trials being put together to select for patients who may have alterations in this pathway to target the CDK4 pathway in bladder cancer patients. Next slide. Another pathway that some of you may have heard of is the HER2 pathway. HER2 is a protein that sends a signal to the interior, from the outside of the cancer cell to the inside of the cancer cell, telling it to divide and grow. In breast cancer, this protein is found at very high levels in some tumors in some patients, and targeting this protein in breast cancer has proven beneficial in those patients who have large amounts of this protein expressed. And there are actually multiple drugs that are FDA approved for breast cancer that target HER2. Herceptin, lapatinib, a new drug, TDM1, are all FDA approved for breast cancer, and they all, we think, might have activity in this subset of bladder cancer patients where the HER2 pathway is turned on. Next slide. In bladder cancer, about 7% of patients have very high levels of expression and amplification of the gene, and about 5% of patients actually have mutations within HER2 that flip it into the on position, essentially, and cause it to signal constantly when it shouldn't be signaling. And this is about the same proportion that is present in breast cancer. And so what this says to me and others is that testing of HER2-targeted therapies in bladder cancer in the right patients makes sense. And there are several trials that have tried to do this, some of which have been successful, others of which didn't employ any selection criteria and so therefore didn't really show a benefit. But this is an active area of research that's ongoing in bladder cancer, and there's trials that are going on both in the UK and others in the United States that are looking at this time. Next slide. Another pathway that's activated in many different types of cancer is the PI3 kinase pathway. PI3 kinase is actually one of the most frequently altered pathways across types of cancers. It transduces the signal. It takes the signal after it enters the cancer cell. It takes it to the machinery that caused the cell to divide. And there are multiple components within this pathway that may be altered to cause a cancer cell to grow. Again, mutations that either turn on switches on or get rid of the brakes on cell growth in other targets. PI3 kinase is itself is mutated and activated in about 20% of advanced bladder cancers. And there are multiple drugs being tested from multiple pharmaceutical companies that target this PI3 kinase molecule. We at Memorial have one trial looking at this question in patients who have a PI3 kinase mutation in patients who have a PI3 kinase inhibitor in patients who have a PI3 kinase mutation. And so trials targeting this pathway in patients who have this alterations are beginning to emerge and hopefully will show significant clinical promise. Next slide. Downstream in this pathway, downstream meaning the next steps in this pathway down from PI3 kinase are two proteins, TFC1 and mTOR. mTOR is a protein that is a sort of central regulator for cell growth. Inhibiting this protein's function has been helpful in some cancer types, particularly kidney cancer and certain rare types of pancreatic tumors. And there are 2 drugs that are FDA approved for those types of cancers, and everolimus and temsirolimus. TSC1 is mutated in between 8 and 10% of bladder cancer patients, and this mutation turns off TSC1, and TSC1 turns off mTOR. So if you get rid of the brake, you end up turning the system on, which is a bad thing. And so trials testing mTOR inhibition in bladder cancer patients with TSC1 mutations are hopefully going to be underway soon. There's one planned with everolimus, and there may be others in the pipeline. Next slide. And in fact, there was a clinical trial that was done with everolimus several years ago by my colleagues at Memorial Sloan-Kettering, where they gave patients with previously treated bladder cancers everolimus as a treatment, this mTOR inhibitor. But they didn't have the technology and the ability and the understanding at the time to how to select patients for this trial. And the trial was largely negative and did not show that there was a benefit in general for patients. But what they actually found was one patient where the cancer melted away and completely disappeared. And so they went back and they analyzed the tumor. This was before the TCGA in bladder cancer, and identified the fact that there was an inactivating mutation in TSC1 and another inactivating mutation in F2, which probably helped. But laboratory investigation showed that if you turn off this TSC1, you make these cancer cells exquisitely sensitive to mTOR. And this is sort of the one case that we all cite as the perfect example of personalized medicine in bladder cancer. That patient is currently still in remission after 4 years of treatment and is still on treatment with everolimus. And so the hope is that we can provide this type of results on a broader scale by picking patients more carefully for clinical trials and enriching for people who we think would be more likely to respond to the treatment that we're giving them. Next slide. Another mutation that's been identified very frequently in bladder cancer is mutations in the fibroblast growth factor receptor 3 protein. This is a protein that is capable of transforming regular bladder cells, bladder lining cells, into bladder cancer cells. It's very frequently mutated in the cancers that are not invasive into the bladder wall. Is mutated less frequently in patients where it's spread. And there are multiple drugs being tested that target this molecule in phase 1 and phase 2 studies. And some of these are now beginning to be tested in bladder cancer specifically. In patients who have FGFR3 activating mutations, targeting FGFR3, we hope, will lead to clinical benefits, tumor shrinkage, prolonged life. Next slide. So how can you take advantage of these TCGA results? That's really the big question for us as clinicians and as patients. And so while chemotherapy can be very active in bladder cancer, it rarely works for as long as we'd like. We now have the ability to do at least a limited version of mutation profiling, like the TCGA has done, on clinical samples from patients who are treated in the community or at academic centers. Many academic institutions are now beginning to profile tumors for these types of mutations. And there are also companies who are starting to get into this business for profit, where they will go back and get a piece of your biopsy and do sequencing of the genes and generate a report that tells the doctor taking care of the patient what might be the, quote, actionable alterations, the changes that are in the tumor that might be useful to be targeted for innovative cancer treatments or clinical trials. Not every tumor, though, is going to have mutations that are useful. While many bladder cancers will have these types of alterations, it is very clear that not every one of them does, and there may be other things that are driving those cancers to grow that we do not know about yet, those particular individual tumors. In addition, not every mutation that we find in these cancers has a drug that can be paired to it. So even if something is causing the cancer cell to grow, we do not necessarily have a drug that can target it. And so this information is not necessarily going to be useful for everyone, but it may identify new treatment options and new treatment opportunities for people, particularly investigational options. And I must make this very clear this is not yet standard procedure for bladder cancer. It may be standard procedure for bladder cancer in several years, and I think this is where we're going to be moving, but this is clearly not yet a proven way to go. But this is the type of things we need to be thinking about as we digest the TCGA data. Seth, do you want to take over?
Yeah. So thanks, Jonathan. I hope that you all are beginning to get a sense of the power of this type of project to reveal a lot of information in biology about bladder cancer that hopefully we'll be able to turn that into new therapies. The next part of the talk is really more perhaps about biology, about thinking about bladder cancer not necessarily as a single entity of urothelial cancer, but with all of the genomic data that we have, we can begin to identify different molecular subtypes of bladder cancer. So what we did in this project is look at the gene expression data. So remember that a gene, the DNA, essentially encodes the machinery to produce a protein. And it's really proteins that are the driving force behind the intended action of a gene in its normal function or abnormal function. And then and the intermediary step is RNA, so DNA to RNA to protein. And there are a lot of pieces of RNA that also can control how genes work in this very complex machinery. So what we did is we took all of the RNA data and all of the protein data and combined it into this integrative analysis, the term that I introduced at the beginning when we were talking about how TCGA is organized. So what we found was that there are three major subgroups of muscle-invasive urothelial cancer. And one type was we called it papillary because the tumors had at least some component of papillary morphology. What does that mean? When the pathologist looks at it under the microscope, it looks more frondular, while it also might have some solid component. When the urologist looks at it, it might look like that. But these are still high-grade invasive cancers. They were enriched with these FGFR3 mutations, which Jonathan just talked about. And interestingly, some of the microRNAs, the little small fragments of RNA material that we know regulate gene expression, the microRNAs that are known to inhibit FGFR3 were found at very low levels. So there was this mutual relationship between RNAs that regulate FGFR3 in this interesting cluster. And so these clusters, the tumors that were in this cluster, would be logical to target with FGFR3 inhibitors, as Jonathan just explained. In the next slide, we looked at the cluster 1 and cluster 2 and also found features that were common with breast cancer. So some of the genes that are altered in breast cancer were also altered in these two clusters, and there was also a very high level of HER2 alterations, again, one of the important mutations that Jonathan just described, and also estrogen receptor beta, which has been shown to be expressed in a high percentage of high-grade cancers. This is a different estrogen receptor that is common in breast cancer. That's alpha. Estrogen receptor beta is unique. It has some similarities to estrogen receptor alpha, but it's a different type of receptor, and it's also important in these two clusters. And in these particular clusters, the HER2 levels were comparable to HER2-positive breast cancer, again, providing a rationale for both understanding the biology and potentially targeting HER2 with the drugs that Jonathan mentioned in these particular subtypes of bladder cancer. And this graph down here at the bottom shows the similarities between bladder and breast and some of the other malignancies that have been studied in the Cancer Genome Atlas project. In the next slide, I'm describing the third cluster, which we called squamous, because now urothelial cancer can differentiate into a squamous type, which is a more typical cancer that you find in the skin, and also in lung cancer and head and neck cancer. And it can also differentiate into adenocarcinoma, which is a gland-forming cancer. And these squamous cancers can sometimes be very difficult to treat with conventional chemotherapy. We found a high level of keratins 5, 6, and 14, and particularly 5 and 6 have been associated with bladder cancer stem cells. And these are the cells that propagate the growth of the cancer, and they've also been associated with resistance to chemotherapy. Some other genes that were expressed, epidermal growth factor receptor, which is another potential target for which there's drugs approved by the FDA. When compared to other gene sets in other studies, there was some similarities to a basal type of cancer that was published by Keith Chan, who's done a lot of work in cancer stem cells, and Sodal, which is the lead author in a very interesting project from Lund, Sweden, where he also described multiple different types of bladder cancers. So this had some similarities to the particular type that they refer to as squamous. And in the Sodal study, these were some of the more aggressive tumors with worse prognosis. So this type of integrative cluster analysis begins to give us some idea about the biology, and also to get us away from this sort of one-size-fits-all when we're talking about urothelial bladder cancer. Now, in this slide, one of the scientists in the Genome Atlas project, Katie Hoadley, who's at the University of North Carolina and is an expert in RNA, she compared the clusters. So BLCA1, 2, and 3 are the ones that I've just described. BLCA4 was a much smaller cluster that we're going to need more data to fully understand that particular subtype. But one of the interesting findings that Katie came up with was that this third cluster also has features similar to a particular type of breast cancer called basal-like breast cancer, head and neck squamous, and lung squamous, which we referred to previously as some of the cigarette smoking-induced cancers. And what I'm pointing out here is particularly these yellow boxes, which is the head and neck cancer and the lung cancer. Yellow means more similar to cluster 3. So one of the really exciting things about the Cancer Genome Atlas project, because all of the analyses have been done very similarly, when all the different types of gene analysis and DNA, RNA, and protein have been done identically across all of these different tumor types. So you can do these very sophisticated bioinformatic types of comparisons to begin to understand how bladder relates to some of these other tumors. So, you know, it may be in the future that we really treat cancers more along the lines of the gene alterations and the pathways that are altered than the organ in which they started. And this is probably one of the most exciting aspects of the Cancer Genome Atlas project. So what's really coming down the pike? And we mentioned at the beginning that the data that we've presented is on 131 tumors. And what's really exciting is that if you look at the third bullet point here, that we're probably going to get to over 400 specimens based upon the tumors that were received by the end of December, when the project essentially closed to taking any new tumors. And so over the next 6 months, all of these additional 268 specimens will go through the same analysis that we've just presented to you, and that the increase in numbers are going to give us a lot more power to do even more sophisticated analysis to validate some of these observations. And as you get more tumors, you will have the power to identify less common events, less common mutations that may potentially also help us identify subsets of patients for targeted therapy. We need to collect additional information about patients who received chemotherapy prior to their treatment, so we can begin to understand about the alterations that are associated with chemotherapy sensitivity. We don't really have any ability right now to ask and answer questions about how do these gene alterations affect outcome and prognosis, because we don't have enough follow-up, and that's something that we're working on in earnest. All of these observations at some point in time need to be validated, either in taken back to the laboratory to work in cell lines and animals. And one of the exciting things that Jonathan and myself and many other people are working on is a National Cancer Institute-funded clinical trials planning meeting to translate these data into the next generation of clinical trials. And so I'd like to turn it over to Jonathan, because Jonathan is leading one of the most important efforts in this field, and he'll walk you through that in this slide.
So this is a trial that is being proposed through the Alliance for Clinical Trials in Oncology, which is a large NCI-sponsored clinical trials network. And what we're proposing is to essentially take the TCGA findings, or at least a subset of the TCGA findings, and create a trial that takes advantage of this data. So we're calling it MATCH-UP, a molecular allocation trial to choose therapy for metastatic urothelial cancer following platinum-based chemotherapy. This is the first time I've ever come up with an acronym that actually works, so I'm very proud of myself. So this trial is going to take patients who provide consent, who have metastatic urothelial cancer, who've previously had platinum-based chemotherapy, and their tissue is their tumor tissue, which has previously been biopsied, is going to be screened for mutations, and also for a particular protein called the retinoblastoma protein, which is which may be lost in bladder cancer. And based on the findings of these tests, patients will be eligible to go into one of three arms. An arm that targets the PI3 kinase mTOR pathway, another arm that targets the fibroblast growth factor receptor 3 pathway, and a third arm that targets the CDK4 pathway that I mentioned earlier. And so if patients have an activating mutation in PI3 kinase, they'll go on the top arm to the PI3 kinase mTOR inhibitor. If they have a mutation in FGFR3, they'll go on the FGFR3 inhibitor. And if their protein shows evidence that the retinoblastoma protein is intact, which would be a precondition for, or a necessary condition for response to a CDK4 inhibitor, they would then go on to the CDK4 arm. There are unfortunately going to be patients who won't meet the criteria to get into this trial, and they would have to be directed to other trials. We've elected to work with a single company that has all of these, that has drugs that target each of these pathways for bureaucratic ease. And so we're hopeful that this is going to move forward sometime in the next 6 to 12 months to operationalize this trial. And I think this is the beginning, this is the first iteration of what I hope will be many trials where patients with advanced bladder cancer will be assigned to therapy based on their personalized profile of their tumor. Next slide, Seth.
So just to wrap it up so that we can have some time for questions, we've learned a lot through this project. We know that there's a very high, that the genome is unstable in bladder cancer comparable to lung and melanoma. We know that there's multiple pathways that are activated in this disease. We have identified many alterations that can be targeted with existing drugs and potentially new drugs that are coming online, and that the brakes are essentially turned off and uncontrolled cell division. We have a much better understanding of the various pathways and genes that contribute to that. And these TCGA findings present an immediate opportunity for translation into the clinic, and also for scientists working in the laboratory to interrogate this incredible data set to validate their own research and extend their own research. And so our job as clinicians and scientists is to get the clinical trials funded and going so we can begin to provide some benefit to our patients. And so that's our last slide, so I'll turn it back over to Vanessa.
All right, well, thank you so much, both Dr. Lerner and Dr. Rosenberg. Again, thank you very much. We'd also like to thank Abbott again for being, for supporting this webinar. For the first question, how can I volunteer to be a participant in this study? Dr. Lerner, can you answer this question?
So in the TCGA study or the clinical trials?
Probably
so the TCGA project essentially no more tumor samples will come into the pipeline. It's unfortunately our government doesn't have an unlimited pot of money for this, and they've allocated the rest of their funding to sequence the tumors that are now in-house and to continue to fund the scientists who are doing the analysis. And as I pointed out at the beginning, there's lots of projects going on. In terms of clinical trials, there will be a trial that's going to be opening at the National Cancer Institute level that essentially any of us who treat patients are going to have access to look at potentially 30 or more different targeted therapies. And while it's not specific for any particular cancer, bladder cancer patients who are in need of this type of trial will be able to access it through their local physician. And Jonathan, do you want to add anything to that?
So I would add one other thing about, two other things. One is that many institutions around the country have their own robust bladder cancer research programs, and if patients are being treated at those institutions, I would urge you to volunteer to be a part of any of their research programs, because this is the way that we're going to be making progress in this field. The people that we owe the most to are the patients who volunteered to participate in the Cancer Genome Atlas. Every tumor that came through represented a patient who was willing to take a risk, and I think that's I think that even though the TCGA is not accepting patients, that is there are many projects that are worthwhile going on around the country. The other thing is a plug for Beacon. There will be, we hope in the coming 2 to 6 months, a Beacon clinical trials dashboard that will be updated on a regular basis that will basically have a fairly comprehensive listing of the available trials for bladder cancer patients. This goes along with their clinical trials matching service that they have, where patients can get assistance from a live person to help them find clinical trials that may be relevant to them. And so there are a lot of different ways to get involved in this type of work.
All right. For the next question, is there any evidence that a vegan diet would help with those stop signs? And I believe that was talking about the signaling pathways. Dr. Rosenberg, can you address this?
So, clearly a vegan diet is a very healthy diet, and I think that on that basis alone, a vegan diet is probably a good thing as long as there's adequate protein. Many of these alterations are essentially fixed in the tumor by the time the tumor is there, that there are mutations in the genes that are present, and so it may not change the stop signs or the accelerator being turned on, but it may influence other things that impact upon that. And so, I don't know that a vegan diet will change the genetic structure of a tumor once it's there. It may be a good thing to try to prevent a tumor from developing, but we don't really know that for sure either. So, but I would say that a vegan diet is generally a healthy diet, and I certainly wouldn't oppose a patient being on one of them. Okay.
For the next question, how much tumor tissue is required for typing? Can paraffin-embedded tissue yield useful results? Dr. Lerner, can you address this one?
Yeah, so definitely paraffin-embedded tissue can be used for many of these types of assays. It works real well for DNA, works really well for protein, and now scientists have adapted some of these next-generation sequencing techniques to be for RNA to be used in paraffin, and it tends to be the richest and most robust resource. Fresh tissue is the ideal tissue type because it's not potentially, there's no damage as long as it's frozen very quickly once it's taken out of the body. So you eliminate any of the damage that can occur with the fixation techniques that are used for paraffin-embedded tissue. The flip side of that is that fresh tissue sometimes is harder to come by because it requires a patient having an adequate sort of tumor sample, because we always are going to send everything we can to the pathologist to get an accurate diagnosis. Now, having said that, very small amounts of tumor, either in paraffin or fresh tumor, can now be used for these very sophisticated techniques. It's really amazing what they can do off of 60, 80 milligrams of tumors. So, so I think that both are useful, and I think that most of the academic centers and cancer centers are doing everything that they can to bank tissue with patients' permission so that they can inform ongoing and future studies.
So one thing I would add to that is that core needle, we can do a lot of this testing on core needle biopsies of tumors, and so it doesn't have to be from a cystectomy or a ureterectomy. The technology is advancing at a rapid pace, and so what we say today will be different than what it'll be in 6 months and what it'll be in 2 years. But the possibility of using small amounts of tissue is rapidly improving, and hopefully we'll eventually get to a point where we can even use fine needle aspirates, which contain very small amounts of cancer cells, for some of these tests.
Okay. For the next question, if you had bladder cancer that is not metastasized, would you want your tumor profile now? Dr. Rosenberg, would you like to address this?
So I think the answer, in my mind, as a patient, the answer is probably yes. And some of that, to me, would depend on the risk of the cancer based on your discussions with your doctors. If your doctors say, this is not invasive, it's not really something that's going to cause a life-threatening problem, it's probably not, at the moment, necessary to get it profiled. If it's a muscle-invasive or very aggressive or node-positive cancer, but it hasn't spread elsewhere in the body, it might be wise to get that information in advance. We have not figured out how important is it to do this testing on a metastasis or on the primary tumor. And that's something we're going to need to sort out over the next several years. We don't have enough information yet in bladder cancer about this. So I think it's a risk-based, my answer would be a risk-based answer. If the doctor is worried about your cancer, I would probably, my own personal feeling is I would do it, although, as I said, this is not yet standard in bladder cancer.
Yeah, so I'd just add a couple of things to that. I think what based upon the previous question, so every tumor tissue that's taken out of the patient is processed in pathology, and that results in a paraffin-embedded specimen that could be used for the types of analysis that would inform a potential targeted therapy. And today, a lot of centers are routinely banking frozen tissue. So I think a priori, I would always want a specimen available in case the need arose in the future. I don't think we're at a point where we can take the genomic profiling and today say, well, okay, you need therapy X or therapy Y or therapy Z. We have to do the clinical trials to ask and answer those questions. But as Jonathan mentioned, they're about, those trials are being developed and will be opening and getting started, in the very near future. But I think that unless a patient, now if a patient is in a position where they've undergone conventional, say, chemotherapy and the cancers come back, then I think that a lot of centers have the mechanisms in place to do the sequencing and ask the question and design a targeted therapy for those patients today under the context of an informed consent.
As part of a clinical trial.
Yes.
Okay. For the next question, a few people wanted more information about the matchup trial. Dr. Rosenberg, can you share how someone could get more information about that?
So I would love for there to be more information. The trial is still being formed, and so there is not a specific document that I can send them to. This is in the process of going through the different starting the regulatory steps towards getting approved. What I would say is that we would anticipate about at least 60% of patients who are screened from a molecular point of view would be able to go on, provided that they meet the other criteria in terms of general health and how well their organs function, like the kidney and the liver and the blood counts. But we expect at least 60% and maybe as high as 75 to 80% of people might qualify based on the prevalence of the targets in bladder cancer as we know it. So PI3 kinase pathway alterations are present in about 30% of patients. FGFR3 mutations are present in about 15% of patients in this population. And the CDK4 pathway would probably be, at least 50% of patients would probably be eligible for that arm, we're hoping. So there may be some overlap, so it's not going to, that obviously adds up to more than 100%. But some patients may have more than one alteration, in which case we're coming up with a mechanism to assign them to the arms based on both scientific evidence as well as rules that the trial is going to set out in advance. And so we're hopeful that the majority of patients would be eligible for this trial. And once we have a trial document, a protocol that moves through the process, much more information will be available.
Yeah, if you want to, so I mentioned this National Cancer Institute funded trial. It also is called MATCH. If you do a Google search on MATCH and NCI, the first hit will take you to the website for this trial, and there's a lot of very useful information that I think speaks globally about personalized medicine and how they're approaching it in this trial if you want to learn more about it.
Okay. For the next question, are there epigenetic factors that you've discovered in bladder cancer for Dr. Lerner?
Yeah, that's probably one of the really interesting findings of this study that had somehow kind of fell a little bit into the background. Actually, when we first found, when we got a call from the NCI when they'd analyzed the first 28 tumors, and that really got our whole analysis program started, that there were alterations in genes that alter how the chromatin, the DNA structure, are put together, and then there's changes in the methylation of DNA. Methylation turns genes on and turns genes off, and these figure very prominently in muscle-invasive bladder cancer. And we actually just had a conference call today that Jonathan actually had for the Cancer Genome Atlas project, and this is something that we intend to do a little bit of a deeper dive into as more tumors come through the pipeline. And this methylation story is really quite interesting. One of the pathologists in the analysis working group, Bogdan Cherniak, has shown he's mapped out from normal to precancer to low-grade cancer to high-grade cancer in the same bladder with multiple bladders. It's an incredibly sophisticated analysis, and what he's shown is that methylation and hypomethylation are some of the earliest changes in the cells that lead up to an invasive bladder cancer. So this is a really important part of the biology of muscle-invasive cancer, and this TCGA project revealed a lot about that, and we have a lot more work to do. Jonathan, do you want to add anything to that? Because this was Jonathan was involved in the very beginning when this whole story began to unfold.
Right. I think it's actually a fascinating story that there's this whole layer of regulation that is altered in bladder cancer, not just mutations, but what is described as epigenetics, and how this is going to translate into cancer care is not totally clear yet. A lot of drugs targeting these type of pathways, these epigenetic alterations, have been tried, but they haven't been tried in a smart way. They haven't been targeted to patients who have particular alterations in particular sort of controllers of this epigenetic pathways. And so I think we have to start over again looking at a lot of these treatments, to look at them in selected populations where we think that if you have an alteration in this epigenetic pathway, you're going to respond to this epigenetic modifying therapy, and if you don't, you won't. And so it's a very exciting and interesting area that we didn't touch on because I think it's one step before prime time still in many ways as far as bladder cancer goes. But it, I think, is also something we're going to hear a tremendous amount about over the next several years.
Okay. For the next question, kind of building on a past one, do you recommend that all bladder cancer patients ask for their tumor to be profiled? Dr. Rosenberg, can you address this?
I think it's certainly a discussion that should happen with their doctor. Not every tumor. I would say if you have cancer that's spread and you're interested in trying to access some of these exciting new therapies, then the only way you're gonna know if there is something there is to have something like this done. The reality is that a lot of insurance companies are not paying for this for bladder cancer because we've not yet proven that it matters, even though we think it does. And so often people are paying out of pocket to get this done. Some centers are doing it on a clinical basis as a research test, and patients are not being billed. But there are limitations to the type of information we get and how useful it's going to be at the moment. And so I think it's a good idea personally, but I don't want to say it as a blanket everybody should do this. I think it's a good idea, and I talk to my patients about it when I think it's appropriate for them.
Okay. And for the last question, for Dr. Lerner, is bladder cancer similar to breast cancer?
Well, it looks like some types of bladder cancer have a lot in common with breast cancer, and what we mean by that is the genes that are turned on and turned off, and the microRNAs that regulate gene expression that are present have certain subtypes of bladder cancer described within the TCGA analysis are a lot like breast cancer. So, the easiest example of this is the cluster that has high HER2 levels. And as Jonathan mentioned, targeting HER2 has been standard therapy for breast cancers that express HER2, and trials are going on already in urothelial cancer with the same targeted therapy approach. And so I think in the bigger context, I think I mentioned this, that the future is really to understand the similarities between tumors that arise in different organs to allow and use the information that may be more advanced in these other cancers and apply it to the particular subtypes of bladder cancer that have those same gene alterations. And I think that we hope that that will accelerate drug development and application in bladder cancer by leveraging these similarities that have been identified in this Genome Atlas project.
All right, well, thank you so much. Thank you both to Dr. Seth Lerner and Dr. Jonathan Rosenberg for presenting tonight. Please tune in to our next webinar on how to be a proactive patient next Thursday, March 6th. And also check out the Beacon website to register for that one and to see some of the past webinars. So thank you very much and have a great evening. That concludes our webinar tonight.
Thanks, Vanessa.